Good evening. I'm Kelly Gear-Ripken, National Chair of A Women's Journey. On behalf of Johns Hopkins Medicine's A Women's Journey, thank you for joining this evening for our monthly webcast series, Conversations That Matter. A Woman's Journey strives to improve your well-being through health education. As we begin 2022, we have all hoped that we would be emerging from COVID. That's why I am so pleased to present an urgent conversation this evening about COVID and the dominant mutation known as Omicron with infectious disease specialist and Senior Director of Infection Prevention at the Johns Hopkins Health System, Dr. Lisa Maragakis. So please use your Q&A on your screen to pose your questions to Dr. Maragakis, who will respond during the last 25 to 30 minutes of tonight's conversation. Our webcast will conclude at 8 p.m. this evening. I'd like to take this opportunity to acknowledge and thank Johns Hopkins University's program, Hopkins at Home, for the production assistance. You can visit their website for additional lectures and courses throughout the year. And now I am pleased to welcome Dr. Maragakis, who has been a gracious speaker at A Woman's Journey during the past 2 years of the pandemic. Dr. Maragakis.
Thank you so much, Kelly. I really appreciate the invitation to participate in today's presentation and really thank the leadership of A Woman's Journey for inviting me to do this.
Well, we're happy to be here. Thank you.
I know that we all wish that we no longer needed to talk about COVID-19 and the pandemic, and yet here we are. So I think this evening, I'd like to share some information with the audience, take your questions, see what's on your mind, and try to offer some hope that we will emerge on the other side of this, and that many of the strategies that we have used over the last 2 years to confront this virus are still the ones that are the best approach. And that I'll start and end with a very hopeful message, and that is that we can do what we need to do while still keeping ourselves and our families and our communities safe, even though this virus and this pandemic has thrown us a curveball by continuing on for so long. So in some respects, we should not be surprised, although I admit that I am. And I think we were all hopeful that we would more quickly emerge from this pandemic. However, here we find ourselves 2 years in, and in our second winter, and at least our fifth surge of this virus, largely due to the emergence of the Omicron variant. So where are we with the pandemic? Well, I'm sure that everyone knows that the Omicron variant has led to one of the largest surges that we have seen during the pandemic response since it first was identified. The virus was first identified at the end of 2019. So although there was hope during this last summer that we would perhaps be looking at better times and having this virus fade into our rearview mirror, here we find ourselves confronting even more surges. And I wanted to first start by talking about what is the Omicron variant? Why is it causing such a surge? So just to talk for a moment about the basic biology of viruses, and that is that they replicate and have mutations that arise on a regular basis as those replications of the virus happen. And so the more transmission that we have, the more infections that we have, the more opportunities the virus has to develop more and more mutations. This Omicron variant has a very large number of mutations that appeared all at once. So I have to say that it was quite surprising, not that a variant emerged, but at the degree to which this variant differs from other versions of the virus that we saw earlier in the pandemic, the original version or alpha or beta, or even the more recent Delta variant. So what's different about the Omicron variant? Well, we see mutations, over 50 mutations, and many of these are in the spike protein itself. And I'm sure you've heard about the spike protein being on the surface of the virus. And this is a protein that is critical for the virus to enter our cells, to bind to and enter our cells, to cause the infection in the first place. And it is also one of the most prominent exterior features of the virus that our immune system recognizes, responds to, and uses to develop antibodies that can actually neutralize and fight the virus. And that's why it's such a problem when we see dozens of mutations arise in this spike protein. And what that has caused is immune escape. What do I mean by immune escape? Well, that means that for those of us who have had prior infections and or vaccines in any combination, and now there's many combinations that can occur depending on when somebody was previously infected and recovered, which type of vaccine they may have received, what type of booster they may have received, and when. So all of that, those are our strategies for getting immunity to recognize and fight off the virus. But those were all developed with these other types of the SARS-CoV-2 virus, the virus that causes COVID-19. And unfortunately, the dramatic change that we see in the Omicron variant means that that virus is able to escape some of those immune responses, whether they were generated due to prior infection or to the vaccines or boosters. So you can imagine that antibodies that were developed now might not quite be able to recognize as easily this virus. The other problem that this causes is that some of our therapeutics, including monoclonal antibodies, which are a therapy that can be given intravenously to people who have been exposed to the virus and are at high risk for severe complications and need preventative medication, and or to those who have started to develop symptoms or tested positive and are at high risk for severe complications and need a therapeutic agent in those first few days of their infection. Those monoclonal antibodies also are not effective any longer against the Omicron variant. So this has put us into a very difficult therapeutic position where we have lost some of our tools to fight the infection, both on an individual level with our own immunity and also on a healthcare and therapeutic level with our monoclonal antibodies. Now, there are three major types of monoclonal antibodies, and the good news is that one of them, called sotrovimab, is effective against the Omicron variant. So that's the good news. We do still have something that we can use. The bad news is that that medication has been in very short supply, and right now we have a tough situation where we have an allocation of scarce resources, where we really have to have algorithms to make sure that we target the use of that medication to those who need it most. And that really falls to the main categories of those who are the most immunosuppressed, either due to underlying immune conditions or to therapies for cancerous conditions, for instance. And so at Johns Hopkins Medicine, we have developed an algorithm to target the very small amounts of this monoclonal antibody therapy to those who need it most. We're certainly hoping that in the future there will be more available. So what else has happened besides immune escape with this Omicron variant? Well, it's interesting. When viruses develop these mutations, it does have an effect on immunity, as I've described, but it also has an effect on how the virus can perform or act on its own, and how transmissible it is from person to person, and the kinds of symptoms that it might cause, and many other parameters of the virus. The good news about that is sometimes viruses that develop mutations just fizzle out because they're really not effective from the virus's perspective at causing disease or being transmitted from person to person. Unfortunately, we are struggling right now with the Omicron variant because it is somewhat of a perfect storm. And that means that these mutations gave it the ability not only to escape our immune responses, but also to cause disease and be very, very transmissible person to person. So that is the unfortunate reality about this variant. So we already knew that transmission from person to person was quite efficient, but what we see with the Omicron variant is that it's even more transmissible person to person. We're not really sure why that might be, but some data from the laboratory and animal experiments shows that it may be because this virus has more of an affinity for the upper airways rather than the lower airways in our lungs. And so there may actually be more virus in the upper airways where it can be transmitted during talking, singing, coughing, sneezing, or other contact, especially if we are maskless. It may be also because of that, that we're seeing more airborne aerosolization of the virus kind of hanging in the air and in these indoor settings, like we know could happen with the previous variants, but appears to happen even more with these variants. Now, it's hard to tease all of this out, of course, because we also know that other factors are changing. And if we've learned anything during the pandemic, we've learned that it is a dynamic situation and that we have to remain vigilant because the virus is changing, the weather is changing, the geographic distribution of disease is changing, and our own behavior is changing, our own reaction to the virus. And one thing that I can say is that I think I speak for all of us in saying that we are tired of the pandemic. And we have seen that pandemic fatigue exhibited in many different ways. But globally, I think it has been seen in a relaxation, even amongst those of us who are the most diligent in infection prevention, a relaxation of some of our approach, just because it has gone on so long. And the combination of this virus that's more transmissible coming at a time when many people were feeling optimistic because the vaccine had arrived and we had gotten vaccinated, hopeful that they could shed their masks. And even here in the United States, we had national guidance saying that we could not wear our masks any longer if we were vaccinated. These factors came together along with general opening up of the economy and public spaces to cause a behavioral aspect that also led to increased risk of contact between more and more people. Travel picked up again. And so we had more interpersonal contact, more maskless contact at the same time that this perfect storm happened of a virus that was more transmissible and had all these mutations to escape the immune response. So where does that leave us and how do we protect ourselves going forward? Well, first, let me say that where it leaves us is in a position where we have had record numbers around the world, record numbers of cases. So the numbers are truly staggering. When you look at the numbers in the United States, we are now above 738,000 infections a day. In the last 2 weeks, we have seen a 200% increase, and the graphs are staggering as well, because you can see that the course of the numbers of cases, if you graph that over time, and if I showed that to you, you would see any graph just having a complete straight line going towards the sky in the recent weeks and months. And this is true really around the world. The timing varied a little bit geographically, but the trends really hold, showing that The numbers of cases that we thought were high before have been greatly exceeded, 10 times more cases in some cases. And so this is really staggering. And I can say that in some sense, as bad as it seems, we have been somewhat saved from this situation because the virus seems to be somewhat less cause somewhat less severe illness than some of the previous variants. And I think it is pretty clear now that that is true, especially if we compare the Omicron variant to the Delta variant. True comparisons between one viral variant and another are difficult because, as I said, during this pandemic response, there's so many factors that are changing at the same time. And one of those factors is the underlying immunity of the worldwide human population, either from prior infection, vaccination, boosting, or any combination thereof. And so we are measuring the effect of the Omicron variant as it hits different populations against what we experienced during Delta wave and other prior variants in a much more immune competent human population. Now, I've already spent quite a bit of time explaining how this virus can escape our immune response, but the fact is that our immune response is still helpful to us, even if we get infected. And we know this from other viruses, including influenza, that even if a vaccine doesn't completely stop the infection, over time, it does at least still give you some protection against the most severe consequences and death from the infection, even if you become ill. And that's the type of thing that we are seeing now with Omicron. So thankfully, with those record number of cases that are happening, our hospitalization rate is lower than it had been in prior surges. Our death rate is much lower than what we have seen in prior surges. These are what we call lagging indicators. So we do have to wait some time after the cases rise to make sure that we understand how many of the people who got the disease will end up in the hospital and how many of those who are in the hospital need to go to the intensive care unit, and unfortunately, how many go on to die of their infection. But all of the data suggests so far that we will see far fewer deaths from the Omicron variant. So that is the really excellent news. And I'm so glad that that is the case. However, I will say that I want to spend a moment talking about the impact on our healthcare system. And this is not just because I want you to understand the stress and strain that's happening in hospitals and health systems, but of course, because our healthcare system is a vital resource for all of us to maintain our health, not just during a pandemic because of the infectious disease, but also because of all of the other healthcare needs that we all have on an ongoing basis. And so I am really concerned about the healthcare settings and our healthcare infrastructure around the world and the stress and strain that happens when we have such a large surge. So even if the proportion of patients who become infected is smaller that have to go into the hospital and get sick enough to require intensive care, the proportion is much smaller, but the numbers are so staggeringly large that we are still experiencing a large number, an unprecedented number of hospitalizations and the need for healthcare services. In addition, you may be aware that the number of patients who are admitted to the hospital with other medical conditions and medical needs besides COVID-19 have also been found upon testing to test positive for the infection and need special isolation precautions. This has happened throughout the pandemic, but again, because the numbers are so large, it is certainly a feature of what we are seeing now and is complicating some of the provision of healthcare services for people who are coming in for otherwise unrelated issues like delivering a baby or having a fracture repaired or having a heart attack or a stroke. And so all of that is also happening at the same time. I keep saying perfect storm, but really, unfortunately, all these factors are coming together at one time. And that is that the community prevalence of the infection is so high that it's affecting everyone, including healthcare personnel. And so we find ourselves at a point where the healthcare personnel are tired, as we all are, of the pandemic, and we have fewer healthcare personnel because we have lost some of our workforce due to the Great Resignation and the kinds of societal forces that have happened over the course of the pandemic. So we find ourselves with fewer people employed in healthcare right now. And then we have many members of our own healthcare personnel getting sick and needing to be out of work due to the infection. So this is really making it difficult to keep hospitals afloat and functioning. And I'm so grateful to all of my colleagues at Johns Hopkins Medicine. And I know that other health systems and hospitals around the world are doing these same strategies to respond to this incredible influx and pressure that is put on the healthcare system so that we can provide healthcare and save those patients who are severely ill from COVID-19, and also continue to provide healthcare services to everyone who needs it, even when it's unrelated to COVID-19. So I will say just a bit about crisis standards of care, which is something that has been part of pandemic planning for a very long time. Throughout my career, I've been involved in pandemic preparedness exercises and planning. And many times we talk about the horrific situation of what if we had more patients who needed mechanical ventilation, for instance, or a medication, and we didn't have enough ventilators for those patients. And that's one of those ethical dilemmas that's almost unimaginable and is very difficult to confront and plan for. But I will say that as I've described, the limiting factor right now is our staffing, how many doctors and nurses and respiratory therapists we have, and actually every role that keeps the hospital going, our environmental services personnel, materials management, every role really has been equally hit. And so we are all pulling together as a community and have implemented in some of our hospitals what is called crisis standards of care. And that is a special group of strategies that were developed initially by the Institute of Medicine and were outlined as a response to disasters, initially after hurricanes and other natural disasters, in order to keep a hospital functioning and be able to respond in a crisis and keep essential services going. And so while it is kind of a frightening concept, I have every confidence that we are providing safe and quality care while this is going on, but it is allowing us a little bit of flexibility to shift personnel from their traditional roles into areas where they are desperately needed to provide continuity of care. And we will continue to do that as long as we need to. And it also allows us to work with political leaders and get the resources that we need and the assistance in some cases. And we have welcomed and are so grateful to some members of the National Guard for coming, for instance, and helping us with delivering supplies and running some of our testing sites and some other functions within Johns Hopkins Medicine. We also have lots of volunteers that are helping us. And it's just one feature I think we all need to be aware of, because in some senses, it feels like many communities have, for very understandable reasons, moved on beyond the pandemic and want to really put it in the rearview mirror. But we do need to be aware of the stress on the healthcare system so that we all can pull together and preserve this resource so that it stays there for everyone who needs it. So how can we protect ourselves? I said at the beginning that I'm very hopeful and optimistic, and I am. I'm a big believer in infection prevention. I know that the basics work. I know that sometimes they seem boring, but and perhaps you'll say, "Oh my goodness, here she is talking about masks again." But the fact is that masks and the basics of washing our hands and being very aware of the fact that anyone may have the virus right now, I think is one of the best tools that we have. And that helps, I think, if you get yourself into the mindset that anyone may have the virus and act accordingly to take the precautions so that when you get that phone call the next day that someone has tested positive, you'll be able to look back with confidence and say, but it's okay because we were wearing masks, or we met outside, or we were distanced, or whatever it may be, that you can be safe and know what your risks are. If you are, getting together for the holidays, for instance, with children who are coming home from college, that you take calculated risks, but understand the power that the package of interventions has, including distancing and masking, hand washing, avoiding indoor eating, particularly when you remove masks. So all those same strategies are so important. But that being said, I do want to say that I think is a false choice to talk about being shut down or being open up. And in healthcare, we've been here all the time, working in the hospital, taking care of patients who have the disease, and we can do so safely. So using that personal protective equipment is important, and it is something that can keep you safe. So I do believe that we can keep our schools open, we can keep our businesses open, and find ways to do what we need to do and keep ourselves safe and get through even this fifth wave that we are experiencing. We don't know what the future holds. It is entirely possible that another variant may emerge, or that we may need further boosters. We know that immunity wanes. We now have enough data following vaccination to know that immunity doesn't last much longer than 6 or 7 months from the vaccine, that we needed this booster. But we also know that the booster dramatically improves the immune response. So if you haven't gotten a booster, I highly encourage you to get one if you can. And we also really need to focus on global vaccination. I have colleagues that are working on this, and I think we need to remain vigilant around the world, that we are all in this together, that we need a global approach to controlling and bringing the pandemic to an end, and that really until we take a worldwide approach to providing vaccine and making sure that everyone is safe, we will all remain vulnerable to the possibility of further variants emerging. So looking ahead, can't say exactly what will happen, but I do think that if we look backwards to prior pandemics, we know that it's not unusual for a pandemic to run a course like this of 2 years. And so perhaps we should have known that we were in this for the long haul, but sometimes maybe it's better not to know, and you take things as it comes. So here we are, and it's at least here in the United States, it's cold, it's winter time, but I'm hopeful that by the spring we will be able to start seeing some of this recede. I will say that I really want to put a plug in again for vaccination. As I'm in Maryland and in Baltimore, and we have been recently, in the recent weeks, in the epicenter of the United States surge with some of the highest case rates in our nation. And we are very cautiously optimistic that maybe in the next days and weeks, we will see a turn and start coming down off of that peak. Some other geographic areas are just entering the beginning of their own surges. And I think we will all have to unfortunately undergo this Omicron surge. And so if you are in an area that is anywhere really in the surge, and you have the opportunity to become vaccinated and have not yet, or you have not yet become boosted, now is the time. Because I do fear for the communities. This has been such a strain on our community, and we have a relatively high vaccination rate. So I really do fear for the communities that have lower vaccination rates, and encourage everyone to get vaccinated. So with that, I think I will bring my comments to a close, and because I really look forward to your questions and to having a dialogue and figuring out what's on your mind. Thank you very much.
Thank you, Dr. Maragakis. Lots of information, and we do have lots of questions. So before we get started, do you think at some point everyone will be infected with Omicron?
Such a great question, Kelly. And, my colleague, Dr. Erin Millstone, and I, at the beginning of the pandemic, really did say that this virus will find everyone. So yes, I'm not sure it will be the Omicron variant in particular, but I do think that this virus is here to stay, and that eventually we will all come into contact with it. So it really is a matter of hoping that that happens after you have been able to get vaccinated and boosted and have a degree of immunity that will protect you once you do get the infection. And that maybe we are far enough down the road that, like the Omicron variant, this virus has mutated and landed in a place where it is less pathogenic at the same time that we have more immune protection.
So with that, though, since you mentioned earlier, here, at least in Baltimore, it's winter time. So how do you tell the difference between, if you have just the flu or the sniffles or something like that, or is it some type of variant of COVID? And what do you do? Do you rush out and get a test? Do you call your physician? Do you quarantine?
Oh, well, it's
too many questions. Sorry.
A lot of questions wrapped up in there. And unfortunately, we've all been in a lot of dilemma here, because our testing capacity is still not what we would wish for it to be. And especially with the amount of virus that we see circulating and the number of cases, we just still don't have the testing capacity, and particularly the convenient at-home quick tests that can give you timely results. So, what should you do? So when you develop symptoms, first of all, the symptoms that you mentioned should not be ignored, because we know that many, many people who are getting the Omicron variant have fairly mild symptoms, which is good news. But it also is something that you shouldn't skip over, because it may be the Omicron variant, and if you pass it on to other people, they may not be as lucky to have mild symptoms. So I do think it's worth taking seriously and getting tested. I know that is a frustrating experience, and that we don't have widespread accessibility of testing, but I do think it's getting better. There are testing sites, and this is one of the big efforts that we have had at Johns Hopkins Medicine, is increasing testing capacity and availability. And right now, the National Guard, as I mentioned, is part of that effort. And so there are a lot of people that are working to try to improve the availability of tests. But it is certainly worth getting tested. To the extent that you can, when you have symptoms, staying at home, staying away from others, even within your own household, trying to isolate until you get that answer is the safest course.
So just to wrap up just on the testing, just so we can move on with these other questions. So how confident should you feel if you get a negative result from a home test? You have a few sniffles going on or whatever, and some of the other symptoms of Omicron, and but you do get a negative test and you've been exposed to someone that tested positive. What should you do? Should you wait and get retested again? I mean, do the test, get retested again in X amount of days? What would you recommend?
There's a lot of different scenarios one can imagine, but the one you described, where you've been exposed to someone who has the virus, and then you have symptoms, and you take a test and it's negative, probably I would say don't believe that test, especially if it was like an over-the-counter quick type of test. We know there's a lot of variability in those tests and how sensitive and specific they are. So in this case, if it quacks like a duck, I think you have to think that it is. If someone in your household has had COVID, in that case, if you're symptomatic, you may not even need a test. You can safely assume that it probably is COVID-19. One caveat about that is that we do have other respiratory viruses that are circulating. Flu is circulating, and other respiratory viruses. So it's possible, but still most of this that we're experiencing right now is COVID-19.
So Dr. Maragakis, would you just lastly, would you wait? How many days should you wait if you're going to do, if you know you were exposed, you're going to do your home test? What would you recommend for your timeline between that? 2 days, 3 days, 5 days? Yeah.
It's so confusing when you're exposed, and once you find out, you want to do something right away, but you do need to wait several days. We say between 4 and 5 days. It does look like Omicron variant may cause disease a bit faster than the Delta variant did, so you might want to shorten that to 3 or 4 days. But the main thing is that one test, if it's negative, doesn't say that you're completely out of the woods. If we think back to the beginning of the pandemic, we know that the incubation period of the virus can be up to 14 days. So really, if you find out you're exposed, you should be vigilant for symptoms and think about getting more than one test to make sure that you don't have it in that next couple of weeks.
Great. Thank you very much. So let's get to some questions. So Cass has her question, and she would like to know, if you have had COVID and quarantine, do you have antibodies? That's part of the question. And then, can you get reinfected? And then what should you do?
Such a great question. So after you have COVID-19, one would hope that you have antibodies, but it's not always true. So again, the answer has to be, it depends. I would say that the majority of people, if they have a healthy immune system, will develop antibodies to the virus after being infected, but that can vary a lot depending on how severe your symptoms were. So testing positive when you're asymptomatic, you're less likely to get that immune response. And people who are unfortunately sicker or sick for a longer period of time with symptoms are more likely to have antibodies. But this is very individually variable. And we know from antibody studies that there's a wide range of how many antibodies somebody will have and how long they last. So I can't fully answer the question, but the unfortunate answer is yes, you can get infected again, either because you didn't have a complete immune response to the first infection or because another variant came along.
Okay, and then obviously if you feel that you've been infected, call your physician.
Absolutely.
Do a home test / call your physician. Yeah.
Right.
Okay, thank you. This is from Elizabeth, and she would like you to please define and speak to the immunocompromised population.
It's so important. And it's one reason that I said we're all in this together. So, even as we see the Omicron variant and most people are having relatively mild disease, and we've heard the phrase omi-cold thrown around, we have to remember that not everyone is so fortunate to have a robust immune response or immune system. So part of our responsibility as a worldwide community is to think about the most vulnerable among us, and that includes people who are immunocompromised due to underlying illness or medications to treat illnesses. And in the immunocompromised, we know that sometimes the vaccine doesn't take as well. A third dose of the vaccine, not a booster per se, but a third dose has been found to be very helpful to increase the immune response among people who are severely immunocompromised. So if you are in that category, definitely worth getting that third vaccine. to try to boost your immune system. And then for the rest of us, we just need to realize, as I think I said earlier, if you're symptomatic and have mild symptoms, please don't dismiss it or skip your isolation period or wearing a mask, because you never know who around you may be immunosuppressed and really much more vulnerable. Also young children and people who are older.
And Dr. Maragakis, on the isolation period, what would you recommend?
So confusion abounds, right? Because the recent guidance that came out over the holidays has confused a lot of people. So just to say a word about that, isolation period for somebody who has COVID-19 conventionally has been 10 days. That is based on studies that showed early in the pandemic that live virus really could not be cultured from people who had the infection after day 10. So that told us that even though they may still have a lingering cough or some symptoms, that they were really not infectious past that 10th day. And so that's why we recommend 10-day isolation. So what happened over the holidays was that this incredible healthcare crisis that I described came to the attention of the CDC. And in order to preserve the healthcare workforce, they very clearly outlined several levels of contingency or crisis response that allowed us to bring healthcare workers back to work earlier than the 10 days. So we are currently bringing healthcare personnel who have COVID-19 back at day 5 because of our severe staffing crisis. They wear masks all the time. We have extensive personal protective equipment and to mitigate the risk of any transmission to other colleagues or to patients. Shortly thereafter, however, the CDC also issued guidance for the general public, shortening the isolation period to 5 days with the stipulation that it's only for those who are vaccinated, fully vaccinated, and that you wear a mask for the additional 5 days to complete that 10-day period. I would say that if you need to do that because you are in a situation like healthcare or some other essential service where you really need to get back to work, this was primarily guidance that was issued to keep our economy going, to keep workforce going. So many sectors have suffered because of workforce shortages. Then wear a mask, wash your hands, take those extra precautions for the extra 5 days. But if you are in a position where you can isolate for the full 10, that is the safest course.
Right. Thank you. So Paula has a question and then it'll go into the next question. But Paula wants to know, what are the rules for house partners if one of the house residents contracts COVID? That's a toughie.
It's a tough situation.
That's really tough to do, especially if you're a house guest. Ooh.
If you're a house guest or a household member, it's almost impossible, as we know from prior viruses. You're close to somebody within a household, it's hard not to get the infection. So to the extent possible, if you can isolate in different, sleep separately, if possible, use separate bathrooms. It really is that same concept, but within the household, or some people actually even leave their household if they have that ability. Again, that isolation period of 10 days applies.
Right. Thank you. Allison would like to know, what advice do you have about talking to friends and family who remain unvaccinated? Because often sharing the data just doesn't work.
These are such tough questions. These are all of these unsolvable problems that we've encountered with the pandemic response. A couple of words of advice. I think that everything has become so contentious and politicized. I think that it is important that we listen to each other. And so trying to be empathetic and listening to try to understand the person's reasons, asking questions, trying not to make them feel bad. I do agree with the question, which is that there are some people that providing data and providing recommendations, it doesn't resonate. But I think expressing empathy, listening to people's concerns, and then providing your own perspective, not in a way of saying like what you should do, but why you came to your own decision, or sharing experiences about friends and family can be helpful and powerful. But there's so many different reasons that people have chosen not to get vaccinated that it's a bit of an individualized approach, and it is getting harder because most of the people who are not vaccinated right now are pretty dug in.
Right, right. Thank you. Our next question is from B. Does your protection increase if you have a booster different from your vaccine, or increase or decrease?
Great question. The data are strongest for the boosters with the mRNA vaccine. So I guess I don't know. There are some data that suggest that mixing and matching, which I think is the question, so that if if your primary vaccine series was one type and you pick a different type, that may give you a stronger immune response. The biggest factor, though, I think, is getting the booster, and really, regardless of what you got as the first vaccine series, the booster seems to do a tremendous amount to increase your neutralizing antibodies.
Great, thank you. This question is from Tamara. If you've had one COVID, how long can one expect for brain fog to go away? And is it a symptom of Omicron?
Yes, this brain fog issue is so difficult. I think that often when we talk about a respiratory virus, we think of the respiratory symptoms, and we're so focused on the oxygen level and whether somebody needed a ventilator. But I know you've had other tremendous presentations by people who are studying long COVID and really trying to help patients who have a variety of other symptoms from COVID-19 infections, some of which linger and last. And brain fog being chief among them. I think of one of these very, very disturbing symptoms that people report with COVID-19 and some other infections. So yes, we have seen it with Omicron. Not everyone has it, but we do see even among hospitalized patients, some of them suffering from neurologic symptoms, including brain fog. I unfortunately can't tell you how long it will last, but I urge you, if you're having something like that, to seek out a provider who is familiar with long COVID and the services to support patients who are having these types of symptoms.
Great, thank you. Our next question is from Beverly. She'd like to know, do hospitals test for COVID upon hospital admission?
The Johns Hopkins Medicine hospitals do. It is not universal that type of testing would be done, but we do feel like it is a very helpful procedure that we do, and we do find a fair number, actually with Omicron, quite a few, as I mentioned, who have asymptomatic infection, and they're coming in for other medical complaints, other medical reasons, and found to have COVID. Not terribly surprising, since the rates are so high in the community that we are finding quite a few who test positive.
Great, thank you. Kathleen would like to know, what are potential long-term side effects of COVID on children?
Well, this is such an important question, and ongoing studies will give us more information going forward. It is one bright spot in this pandemic that our children have been largely spared from the brunt of the worst cases. That is not always true. In prior pandemics, younger individuals have suffered, even more than older ones, depending, I think, on maybe the immune makeup and other viruses that have been seen for influenza in the past, for instance. But during this one, largely the pediatric population has had mild disease. Of course, we know that some have had very severe disease, and we have had pediatric deaths. The long-term consequences for those who have disease and recover, I don't think we yet really know. the extent of long COVID, for instance, or the long-term impact.
Thank you. These questions are just rapid fire coming in, I can tell you. So this next question is from Dana, and she would like to know, should healthcare workers return to work if they are COVID positive but asymptomatic?
Well, I mentioned the contingency level that we are currently using at Johns Hopkins Medicine, and so we've had to make some tough choices between asking people to come back early and preserving our workforce to be able to maintain clinical operations and provide the care that our patients need. Certainly, I think that healthcare providers who are asymptomatic are in the best position to come back early. We are using that contingency level where they come back after 5 days of isolating. And of course, wearing a mask and taking all the precautions. There is a crisis level that the CDC outlines, and I believe some hospitals have reached this level. I heard earlier today that some in California have, where they are not isolating at all for healthcare personnel who test positive and have no symptoms and are continuing to work. And I believe that that is due to the extreme shortage that they are having. I do think that in healthcare settings, we have so many tools at our disposal to protect ourselves and our patients and to interrupt transmission. So we use universal masking, we use face shields, we have distancing and protocols in place to keep everyone safe. But it's not ideal for sure.
Right, exactly, understandable. So our next question is from Leela. She said, I understand the booster shots are no longer effective, she's saying after 3 months, and you can see if that's correct information. What do we do then when they are no longer effective? And are there plans to provide more booster shots?
There are plans, not concrete plans yet about when we might need another booster. I'm not sure we yet really know how long the immunity from the booster is going to last, but we're starting to find out because people got boosters a few months ago. And so we're starting to be able to map out the range of immune response to the booster and how long it might last. And so I don't have a definite answer for that, but I think we will be learning more. And I think the more and more that we see about the immune response to these vaccines and boosters, we know how important the vaccine and the boosters are, but we also know that they are time limited and that we will likely need repeated boosters. I know that the vaccine companies are also working on tailoring their vaccines to the latest variants. So it's possible that future boosters will be targeted more to certain variants.
So do you feel that we're kind of moving in the direction that we'll be getting more boosters, sort of how we get the flu shot?
I would imagine it will look something like that, yes.
Mm-hmm.
That it will be like a seasonal thing where you could imagine that happening, where we would do something similar that we do with flu, which is keeping an eye on what's circulating and providing annual boosters or shots, to protect against the circulating variants.
So by doing that, then would you say then it helps to keep the variant down so it's not as either maybe not contagious, but is not as severe, symptoms are not as severe? Like basically the Omicron, where you're saying is the symptoms have not been as severe for the most part for most people. And so as this continues on and it mutates into something else and then something else, does it become milder because we're getting these booster shots?
Well, there's two things at play there. So one is what's happening to the virus itself, and then the other is what is happening to our immune system as a global population, our herd immunity, if you will. So the virus itself there is, at least in the past, in pandemics, there has been a movement towards milder and milder forms of the virus until it kind of becomes a more endemic, seasonal type of virus. And so we may see something like that happen with this virus. It is still possible, however, that a variant might emerge that would be more pathogenic and more capable of causing severe disease. So we need to remain vigilant for that. So we can't really predict which variants will come and what characteristics those viruses will have. But what we do know is that over time, as we see different versions of this virus sweep through populations, we will gain more and more immunity and ability, kind of cross reactivity, I guess, so that our antibodies can help protect us, not maybe from the infection, but from the severest forms of the disease.
Sure. So with that, there's a question from Samantha. So she'd like to know, because we're getting these vaccines and boosters and such, should we delay other vaccines like shingles vaccines? Because we're having all of this injected into us.
Right. Yeah, I would not advise skipping other vaccines. All of our focus is on the pandemic, of course, but other things are happening. And so if it is time for you to get your shingles vaccine or your pneumococcal vaccine, your flu vaccine, we recommend that you get those vaccines. Now, you might not choose to get it, on the same day, but your immune system is perfectly capable of responding to different stimuli, and we do that in our childhood vaccines all the time. So
Right.
Don't skip your other shots.
Good to know. You heard it here. So the next question is from Cheryl, and she would like to know, if children develop COVID after their first vaccine, should they delay their second vaccine shot or just move on with it?
They can move on with the series. Of course, the timing depends, but in general, the only reason to delay would be if they're in that active infection period and on isolation when it comes time for them to get their next shot, and then they would wait until they're finished with their isolation period and feeling better before they get the second shot.
Mm-hmm. Thank you. Mm-hmm. Christina wants to know, is there now adequate PPE and other supplies to keep up with the surge?
There is, thankfully, and I can't say that that's true everywhere, but certainly in Johns Hopkins Medicine, we've been fortunate, and I have not heard of the types of shortages that we experienced before. So we have gowns, gloves, masks. Yeah, we're doing well now.
And also, Dr. Maragakis, speaking of masks, just for one question, do you have a preference, the cloth ones or the ones that are more like the medical masks, just the paper ones? What do you recommend?
I'm so glad. I'm so glad you asked about this. So many people have been, unfortunately, in my opinion, on television saying that cloth masks are worthless and should be thrown away and that we all need to wear respirators. So just a word about that. The real cause, I think, of the vast number of cases that we're seeing is the infectivity of the virus. And also, as I mentioned, our behavior changed. And so we do contact tracing within Johns Hopkins Medicine, and we know that our personnel are getting the virus in the community from household contacts and from maskless contacts outside of work. So we're reminding everybody that wearing a mask, any kind of mask, is better than not wearing a mask. And so just remembering to choose a mask and avoid those higher risk maskless interactions is the best thing that you can do. I don't think everyone needs to be in a respirator, meaning those tight fitting N95s or KN95s, but just wearing a mask and remembering the risk factors is the main thing.
Thank you very much. Dr. Maragakis, we could go on and on. We have so many questions out there, and thank you all for that. So unfortunately, we're approaching the 8 o'clock hour. So I'd like to take this opportunity to thank Dr. Maragakis so much for your time and expertise this evening. It's always wonderful to see you. And I'd like to thank all of you for joining us this evening. In the coming days, a video of tonight's live stream will be available on the A Women's Journey website, hopkinsmedicine.org/A Woman's Journey, under Conversations That Matter. And if you'd enjoyed tonight's discussion, please check out our website, hopkinsmedicine.org/A Woman's Journey, for information about future conversations and podcasts, all featuring Johns Hopkins physicians and faculty, brought to you by A Woman's Journey. In the meantime, we hope you will find our monthly email informative and engaging. Good night and stay well. Thank you.